All right, ankle and foot disorders. I'm going to go through this so that you actually get out of here on time for your break. I want to respect your break time. So I'm going to hit only the highlights as necessary. The anatomy of the ankle has to be known. 5 bands laterally, 1 major band medially. What does that mean? Well, let's pretend you're like from the old school and you actually examine somebody. Oh, heaven forbid, oh my God. When you examine the medial aspects, you're looking for stability of that joint. If they're unstable when you move them laterally so that the medial, the deltoid ligament is the one involved, those things are sometimes surgically corrected. Laterally, that's the standard one, the times 10 sprained ankle is you've gone like this, you've turned your foot, inverted it. So it's stretched on the lateral aspect. There are 5 major bands there. So you may tear partially one. It's rare. In fact, I've ever seen it where they've actually torn all 5. All 5, yeah, that'd be a surgical problem. But medially, it's the deltoid ligament. That's what you're going to palpate with your fingers. If they've got a lot of swelling and tenderness over that, you got a problem. Now, I'd like to talk to you guys about plain film interpretation, but most of you don't care. You either see a fracture or you don't. The question is, when do you take a picture? The Canadians do believe in the Ottawa ankle rules. That is, if you can't stand weight, if the ankle will not support your weight at the scene or in the emergency department, yeah, they'll shoot a picture. But pretty much they want something like point tenderness over the lateral malleolus. Okay, they'll shoot a picture. Other than that, they don't understand it. Bulky it up, ice bags, crutches. If it's not, start slowly walking on it in 4 or 5 days. If you handle it, great. If you don't, you come back and get a study. Let me stop the discussion right now about the next study you get. In this country, what have we done? We've said, well, it's not getting better. We didn't see a fracture. We'll shoot a CT scan. I don't think that's right anymore. Just like it's not right for the knee, it's not right for the wrist. Study of choice, and we always say, well, they're so expensive, is the MRI. I'm sorry. It's not high cost, it's high charge. I'm an economist. The cost, we bought the machine, right? We paid for the machine. How much does it actually cost you to shove one more person through it? And the orthopods are pushing us in this direction. They want to answer the question. I remember in the 1990s when everybody's knee got what? A scope. What happened to the knee scope? What happened to it? Disappeared, right? Why? Because now they can get an MRI. The MRI actually dropped the cost of knee injury in the country because they make their decision, surgical yes or no, based on a study. So think about that. Now it's 2 weeks, their ankle isn't better, they're non-functional, shoot the MRI. Just get the study of choice to answer, is there something a surgeon can do, yes or no? And I think that's the way we are at this point in time. We point out the Oz misdiagnosis. The Oz trigonium is normal radiologic variant. You should keep a book in your department that has normal radiologic variants, particularly with regard to kids, and just open the book and say, is that normal? That's normal in up to 14% of people. They've got it circled there nicely for you. That's not a fracture. That's a normal variant. Ossification centers, I'm not going to go through because this is mostly with kids. You can always look that up. But the sprained ankle overview is 5 bands on the lateral aspect, 1 on the medial aspect. The Ottawa ankle rules are stated. Now, We do this, we tell you about this, but you won't follow it. Why? Because of patient satisfaction questions. They came to the emergency department, as far as they're concerned, for what? An x-ray. In fact, one of my partners suggested that, you see, certain things I don't x-ray anymore. Small toes, ribs, noses. One of my partners suggested we keep one set of nose x-rays in the department. So when people say, well, I want a nose x-ray, say, here's one. And then they're going to say, it's not my nose. No, but it's a perfectly good nose. And we're not making any decisions on it. Truth of the matter is, we don't make many decisions on a lot of things. But it sort of makes people happy. The Salter-Harris fractures have to do with children. Salter and Harris, of course, were at the Hospital for Sick Children in Toronto. That's just down the street from the Hospital for Well Children, of course. And they came up with this system. You don't really need to know this terribly well. If you've got a fracture somewhere in the ankle of a child that involves the growth plate, they need to be seen by an orthopedic surgeon. You know, the term means orthopeda, straightening of children. Well, if it involves the actual growth plates, somebody ought to see them, because some of these are going to require real intervention to maintain length of the bone and growth. So the Salter-Harris fractures are for real. What about the fifth metatarsal fracture right there at the base, the dancer's fracture? You pick these up. If you're surprised when you get this, you haven't learned to examine. You feel the foot, and by the way, we view the foot and the ankle as a unit, but not for x-ray purposes. Do you all remember the days when they used to get a foot and ankle? Well, that was the dumbest thing possible. It's never the foot and ankle, unless you've dropped something 10,000 pounds on that area, I guess. But most people don't need both x-rays, but what they need is they need examination of both. Old guy, a joint above, a joint below the area of injury should be documented on the chart. Joint above, joint below. I can't picture doing it any other way. Sorry, folks. That's the way it ought to be done, so you can decide what to do. But in this case, joint above, joint below, you're going to pick this fracture out every time. And when they've got that point tenderness at that one spot, pretty much it's broken. There's a diaphysis fracture. They can be confused here, but it requires, this is basically conservative care and non-weight bearing for a while. They almost all get better. It is only in a very unusual group of people where there's a separation that it requires any surgical intervention. Let me move on for just a second. Stress fractures. These are march fractures. These are people who have been doing repetitive activities. Again, these were the soldiers' fractures who went on 20-mile hikes, that sort of thing. Frequently missed. These are the people, and it says here, CT or MRI, just understand now, most orthopods, we've sent them out, they've been on their crutches. Most of our lives is putting people on some crutches, a bulky wrap, and hoping to hell they get better, right? Isn't that most of our life? But you're going to have those who come in who a week later or 10 days later are still painful. Next study of choice is the MRI. Do these things need to be operated upon? Almost never. But they do need a series of castings, and it may be over a period of months. So there may be serious disruption of the life, and you ought to know what you're treating. Now, stop. We're now going to get into something you really do need to know about. Again, mine's a medical legal background. I watch people get sued. People don't get sued over most sprained ankles. They don't get sued over the fifth metatarsal. I've never seen one. I've seen 2,400 cases. I've never seen one of those. This I've seen a dozen of. The Lisfranc fracture. This takes place where your metatarsals join your ankle, the rest of the bones of the feet, up into the ankle. You may not have anything visual, but when you look at the patient, oh my God, again, don't look at the picture first, look at the patient. And if at the midfoot, you take them and it's swollen, and you go like that and they're off the bed, could be a Lisfranc fracture. And I've seen this missed a dozen times where the sinking of those metatarsals may be a couple of millimeters. But to do that, you have to rip the living hell out of all of those soft tissues. I had one where a gal she was on the back of the motorcycle, stuck her foot out for some reason. Just what she needed to be wearing was flip-flops, all right? Caught the thing, bang, squeezed that thing right down, comes into the department. Somebody says, and of course, somebody at triage got a what? An x-ray. Okay, they're looking at that. Everything was turning to crap in the department, so she kind of gets put at the end of the line. Was there a slight change? Yep. What's the downside of Lisfranc? They can have a disruption of the vascularity to this area. By the time they got into she had a foot about the size of a watermelon, and now it's turning colors. This is an orthopedic emergency to reestablish the blood flow to those areas, because you can get necrosis of the tissue in a very short period of time. Lisfranc fractures can be missed. They have a pain out of proportion to reason. These are the people who do claim on the scale of 1 to 10 that it's a 12. Weight bearing is essentially impossible with these folks. Here's the danger. The way we train, the way I like to train residents to say, okay, in fact, I've got a folder, call it my 50 important x-rays of emergency medicine. I throw up the x-ray and I say, what is it? What are you worried about? What can you get sued for? What can screw up the patient? And I ought to hear those just like bullets out of a machine gun in each one of those. So I have a Lisfranc fracture. The complication is compartment syndrome. Listen again, compartment syndrome, because in the lower extremity, the term compartment syndrome is what you're concerned about, because that's big time. It's big time money loss. It's big time damage to the patient. It's big time pain in your ass for the next 5 years if you miss it. So compartment syndrome is real, and these are potentially serious injuries. I always remember one of the orthopods coming in to see a Lisfranc that I'd seen, tissue swelling. There was actually a sizable disruption. I mean, this required, you couldn't miss one. This is a Where's Waldo fracture. This is just, it's easy to find. He looked at it and said, she'll never step normally again in her entire life. That's how bad these things are. You don't realize it. You can avoid using your hand for a while. You can't avoid stepping on your feet. Pay attention. We're going to move on for just a second. Calcaneal fractures are real. There's Broller's angle. Should be 20 to 40 degrees. You can look in the book as to how to do it. But understand where these come from. When you drop, these are axial loading injuries. When you drop on your ankles, I had a most unfortunate gentleman who slid down a ladder. He was working on an oil storage tank. They had a 40-foot ladder. Well, he slipped. He did hold on to the sides of the ladder, and he had gloves on, didn't lacerate his hands, but he came down on both heels. Bilateral calcaneal fractures. He never walked normally again in his entire life. This is an important injury. Just because you don't see it doesn't mean it isn't there. If the calcaneus, if you take it and squeeze it and that is point tender and they can't weight bear on it, that one needs to be followed up by the orthopedic surgeons. Maybe not tonight, assuming that the rest of the foot is normal, but those can be complicated cases and can go on to non-unions, and it is just a huge pain. Calcaneal injuries are real. We'll move on for just a second. I'm not going to talk much about toes because small toes, basically you don't need your small toes to walk. You all know that, right? The only toe you really need is the big toe. Small toes, you got a lot of them. You know, if we need to cut them off, we need to do something like that, they're fine. They'll do okay. Whenever you've had a major problem, they've dropped an anvil. I had this. Two guys are carrying an anvil out of a shop. They did not have steel-toed shoes on, which we were always required to wear when I worked in the steel mills. They dropped it on their toe. All the toes burst open, just like that. Boom! They just burst open. And the orthopod was actually in the department when this guy came in, and I said, "What do you think?" He says, "Do nothing, Greg. Don't try and sew anything. Don't try and align anything. Fluffs between the toes, a bunch of antibiotic ointment, put him up in bed, and I'll see him tomorrow." And 5 days later, when the swelling went down, they actually worked on the guy. But that's really, just understand, sometimes doing nothing is the most important thing you can do. Achilles rupture. Does it happen? Yep. I like these cases, actually, because they're so much fun to diagnose. You don't need a picture. All you got to do is put them on the belly, feet over the end of the cot, and squeeze. This is the Thompson squeeze test. If you squeeze the uninvolved leg, what happens? The foot goes like this. If you squeeze the involved leg, the foot doesn't move much. You can make this diagnosis. I've never seen this diagnosis not made. I've never seen a lawsuit on this case. Why? Because you can't miss this one. Thompson squeeze test. Lay down. Squeeze, squeeze. Foot moves, it doesn't. Now, real question is going to be, what are they going to do about it? But they're going to do nothing about it that night. Again, this is ice bags, crutches, and the decision is, are they going to treat it operatively? That depends on your age. Or are they going to treat it with casting? At my age, at this point in time, since I don't make my living, shooting baskets or anything like that, I'm going to handle this probably closed. If you're 25 years of age and you make your living doing this, they'll take you to the operating room. But ortho will make that decision. Gastrocnemius actually lies behind this. If they've got pain in the same spot, difficulty pushing down, but the Thompson squeeze test is still pretty good, it could be the gastrocnemius, which has been torn. I'm not going to go through all tib-fib fractures except to say this. When you see tib-fib, think what? Anybody? Compartment syndrome. Tib-fib equals compartment syndrome till proven otherwise. If you don't make a comment on all the aspects of a compartment syndrome, let me get to that here for just a second, the 5 Ps. Your chart is inadequate. Pain level, is it out of proportion? Paresthesias, paralysis, pallor, and pulselessness. This is what you comment on the chart. The other thing is you warn. If I've come to the point now where if it's tib-fib, first 24 hours, it's coming in. Because I've seen so many of them go bad, and when they start to go bad, you can go from 0 deficit to damn near necrotic tissue in 4 hours. You can go there in 4 hours. This isn't an orthopod will see him in the morning. If I've got any of the findings, they're coming in that night to see the patient. And let me tell you about a lawsuit I have. Young man, high school, he's a place kicker. He kicks 200 balls an evening. 200 of them. How good is he? He's got a letter from LSU for the next year. The last 2 kickers from LSU went on to the pros. So this kid comes home from practice, and this is a tough 5'8" in all directions kid who's meaner than a junkyard dog, and he's crying. And his dad takes him in, and they shoot a picture. They shoot a picture and say, well, there's no fracture. We'll give you some Vicodin tablets. Go home. Family calls back in 2 hours, and the dad says, this kid's crying more. What should they do? Come back. Don't ever practice medicine on the phone. You're not that good when they're there. Okay? You're no damn good on the phone. But the nurse said, why don't you double the pain medicine? Now, 2 hours later, he's in the department, and of course, he has pallor. The pulses are down. He has unbelievable pain. And of course, the orthopod said, well, we got to take him to the operating room. You don't have to have a fracture to have compartment syndrome. We done now? If it meets the criteria, it's compartment syndrome. That's what it is. Now, they dug the muscle out of his leg, which was necrotic. And when the lawsuit came, he was suing for the average life earnings of a National Football League kicker. And the first thing they presented at trial was the number of 40-yard field goals he'd kicked as a senior in high school. You want to be there, folks? You say, well, the orthopod said it's all right. Shut up. Your job is to protect and defend the patient, okay? If you're I'll tell you what, if you're getting that crap, you better get the doc who's in charge of the department at that moment involved in this discussion, because this is time dependent. Most things we do doesn't matter. This matters. Time is muscle. It matters. There they are. They're opening up that leg. You can see the duskiness, and they know they've hit the right compartment when the color returns and it starts to do what? Bleed. You want it to bleed. All right, ladies and gentlemen, this is my last time with you. It's been a pleasure. Thank you very much.